Good afternoon. We want to welcome you to our Nox Medical Industry Theater, Closing the Gender Gap. My name is Emerson Kerr. I am very excited to be with you today. On behalf of SK, our leadership at Nox Medical, we welcome you. Today is fun. We're going to talk about something that is a very interesting topic. It's a passionate topic. But today we're going to mix some facts with our passion. And to begin with, before we get really started with it, I want to introduce you to our panel. As you can see, we have Dr. Anisha Arora. So let me tell you a little bit about Dr. Arora. Dr. Arora just recently got promoted to full professor of medicine at NYU's Grossman School of Medicine in the Division of Pulmonary Critical Care and Sleep Medicine. Clinically, she is focused on the diagnosis and treatment of sleep-disordered breathing. Her research interests include examining cardiometabolic outcomes, sleep-disordered breathing with a focus on sex-specific differences. Dr. Arora has served on the ASM Foundation Board of Directors since June 2017 and became the president in June 2023. She previously served on the ASM Board of Directors and is currently the chair for the ASM Guidelines Advisory Panel and associate editor for the JCSM editorial board. Welcome, Dr. Arora. Also with us is Dr. Monica Malampalli. She is the president and CEO of the Alliance of Sleep Apnea Partners, also known as ASAP, a nonprofit patient-oriented advocacy organization focused on promoting and advocating for screening, diagnosis, treatment, and management of OSA for optimal health of those living with sleep apnea. She brings a unique perspective to the sleep apnea community as an OSA patient, but also as a trained biomedical scientist and policy advocate. For 15 years, Monica has been advocating for advancement of women's health, starting when she first joined the Society for Women's Health Research based advocacy group. Monica has a PhD in human genetics from the University of Utah and a master's in science and biochemistry. She completed her postdoctoral training from Johns Hopkins School of Medicine in cell biology and then worked at NIH for 2 years as a research fellow and then as a policy analyst. Most recently, Monica was appointed by the ASM to the newly launched Women in Sleep Task Force. She also wrote an op-ed in the ASM Montage magazine titled Shining a Spotlight on Women and Sleep. And finally, Dr. Sinan Baran. Dr. Baran is our medical director at Nox Health and previously worked in academic sleep medicine at the University of Michigan Sleep Disorder Center and with the U.S. Navy at the Naval Hospital in Jacksonville's Sleep Lab. So welcome all. You know, when we think about what we're doing in sleep medicine, you know, a lot of the rules were built for guys like me. I know I'm terribly sexy, but the reality is that, you know, an 18-inch neck guy is what the rules were really made for. But recently, I say recently, it's sort of a 20-year story. A family member of mine was complaining of all the signs and symptoms of sleep-disordered breathing. So over years and years, I encouraged her to talk to her doctor. And so she finally does. It took about 20 or 25 years to get there, and so she did. And the next thing we know, she gets a device in her home. It's a PPG device. And okay, she lets me know this is what she's received. I said, absolutely, wear it. Let's see what happens. It comes back negative. And so I said, listen, I understand it's negative, and your first reaction to this is to think that you don't have sleep-disordered breathing, but I want you to go see your sleep physician. Ask your primary care doctor for that visit. So she finally does. And she goes and she has an overnight study in the sleep lab. It comes back negative with a phone call from the nurse practitioner saying, we read your study, you don't have sleep apnea, you don't need to come see the doctor. So she reached out to me again and said, yep, I don't have sleep apnea. I said, listen, you probably have upper airway resistance. Please go see the doctor. And so she finally does, reluctantly. And that's exactly what happens. And so the physician's a friend of mine, and she said, Emerson's right. you actually have upper airway resistance, but we were looking for sleep apnea. And there's two stories here. One of them is, without an advocate advocating for a clinical pathway beyond what this patient needed, she would have stopped at, you don't have sleep apnea. And then we would have been talking about why is she tired, what medication would have benefited her for her tiredness, and then what medication maybe would she need for insomnia. And now we're in the vicious cycle of pharmaceuticals that she never needed. Now what's happened is she's been prescribed an oral appliance, which is what was needed all along. Right therapy for the right patient at the right time. So when we think about this story, it's complicated, right? It's not an easy situation, but it's part of why this is so personal. And there's another part to it too, and it's a question I've been asking many medical professionals when I've shared this story. Why does a woman have to pay more for her health care than a man? Because that's what ends up happening. And I think a lot of what we're going to talk about over the next few minutes is what can we do differently? And so my first question to our esteemed panel for Dr. Aurora is, looking at this story and this personal situation that we faced in my life with this family member, what does the scientific evidence say now? We've always looked at this as sort of a man's disease. A lot of the research is, like I said, built around guys that look like me. But the reality is there's a broader story. There's more detail that we can learn from this. So, Dr. Aurora, can you share some of the scientific research?
Okay, good afternoon, everybody. Welcome. I am super excited to be here. I'm just gonna open my notes. Okay, so, oh, perfect, okay. Again, Nisha Aurora, it's a delight to be here. And I'm gonna start by just showing you some of the prevalence data. So undoubtedly, the initial prevalence of OSA was reported to be markedly higher in men than women. And you may recognize some of these numbers. This is from the landmark article in New England Journal of Medicine, published in 1993 by Terry Young, which showed that men had a lot more sleep apnea than women. And then when you were in the clinic, they had 8 to 10 times more than the women. But since then, we know that there have been numerous studies, Hypnolaus, there's been some reanalysis of the Wisconsin sleep cohort data, which was the original New England Journal of Medicine data, that shows that worldwide estimates, this is just one study that was published in the Lancet Respiratory Journal in 2019, that demonstrated worldwide that the prevalence of obstructive sleep apnea was much higher than we initially thought, including moderate to severe sleep apnea. And what was really interesting was that gender gap was really much closer than we thought. So now we're looking from 8 to 10 to 1 to like 1.5 to 1. So really narrowing that gender gap. And guess what else? Women were coming to the sleep clinic a lot more. Yet, what's really kind of disappointing and sad is that 90% of women especially, including those with moderate to severe sleep apnea, continue to remain undiagnosed. So this is really a big problem. And what some of the reasoning for that is as follows. We all know this, we've all heard this. Well, men present differently than women. They present with more of the classic symptoms: snoring, witnessed apnea, daytime sleepiness. Women tend to present with more of the sort of atypical insomnia, fatigue. They use different words, right? Nocturia, but also things like morning headaches. These are really, really important things that we are missing and need to ask first. And there was actually one study that I read that women ended up going to 4 different physicians on average before being diagnosed with sleep apnea. So, coming back to Emerson's point of cost of care, why it's different, this is some of the reasoning of why it's different. And we really have to think about our screening methods for case identification. This is really a major issue. And I think what we need to do is give a little special attention to the Epworth Sleepiness Scale, because it's probably the most widely used instrument. And as we already know, women are less likely to present with sleepiness as a complaint and more likely to present with those atypical symptoms, which the Epworth is definitely not capturing. But in case you didn't know, the Epworth has actually not been validated in women, and it's more likely to detect sleepiness in men and women and across all severities in men, whereas in women, it's only more likely to capture the OSA or get screened positive in the moderate to severe. There was actually a very interesting study. I haven't put the reference on here, but I can definitely give it to you all. From Morell, again, looking at the Wisconsin sleep cohort, looking at objective sleepiness, MSLT determined sleepiness in women, and especially postmenopausal women, where we see that sleep apnea prevalence really jump up compared to men. And they found that women were more sleepy on MSLT, but still didn't report it on Epworth Sleepiness Scale. So when we start, when we're using this Epworth scale in our clinics, we have to remember that we're going to end up possibly neglecting a lot of women out there with sleep apnea, and that's a big problem. Now, some of the other scales are also worth saying a few words about. So some of the problems is that many of the symptoms that these screening tools are capturing are based on data from studies that primarily included men. And one of the best examples is the stop bang, right? Which inflates the score if you're a man. And what happens is that if you're looking at a cut-off threshold on these screening questionnaires to give a referral for sleep apnea testing or to refer for a sleep specialist, you're going to end up not referring the women and just mostly referring the men. So that's a big problem. Turns out the Berlin questionnaire seems to have the highest sensitivity in both genders in terms of OSA specific. But also remember all these other symptoms that the women present with, fatigue, insomnia, there are actually questionnaires out there that look at those. And what I've done in my clinic, the one at Centers for Women's Health at NYU, we started a sleep program there, is that we actually, in our EPIC system, have the ISI there and the Epworth there. So we want to capture both sets of symptoms. And I think it's important to think about that, and also to think about how we can incorporate these other screening tools, or think about incorporating a different cutoff, gender-based cutoff, so that we can capture these women. Now, the last thing I would just want to point out in this, sorry, this is not working. There we go, okay. For the women specifically, don't forget, when a woman is sitting in front of you and having sleep issues, you really need to think about where they are in their reproductive aging, right? Because we know that menopausal women have a much higher prevalence, 2.6 times that of premenopausal, but also don't forget about your perimenopausal. So that period leading up to menopause can last 3 to 8 years, and there's an increase in sleep apnea in those women, and that can be a pretty long period of time. So this is all the things you want to think about in terms of screening. Now, yeah, we want to screen, we want to diagnose, we want to do all those things, but for me personally, the thing that I am most worried about, and the reason I really screen, is because there is a lot of mounting and somewhat alarming evidence that obstructive sleep apnea is actually associated with worse health outcomes in women versus men. So these next two slides are just a big laundry list of some studies, not even all of them, published in the last decade that demonstrate that actually women have worse cardiometabolic outcomes when sleep apnea is added to their picture, worse than men. And this could be simple blood biomarkers, these could be intermediate markers like endothelial dysfunction, these could be from large Medicare databases looking at diabetes, depression, hypertension, cardiovascular disease. So there is definitely an interaction of sex, OSA, and outcomes. And we really want to not forget that. And that is a major, major reason why I worry personally about screening for the women I see in my clinic for sleep apnea. One thought that I do have is that the sleep apnea may be coming later in their life, and they are at that time having increased cardiovascular risks. So when you add sleep apnea on top, you really accelerate their adverse health outcomes. Just something to think about. Adding to this big laundry list of data is some of our own kind of exciting data, some of it published just earlier this year. So this is actually a study that we looked at overnight nitrate levels in men versus women in type 2 diabetes, well controlled, and newly diagnosed obstructive sleep apnea. Nitrates are a marker of oxidative stress burden, and we know that obstructive sleep apnea increases oxidative stress. So let me walk you through this a bit, just one slide. So on the left here, do we have a pointer here? Oh, sorry. Okay, on the left here, you have a figure. The y-axis represents change in overnight nitrate levels. So it's morning nitrate levels minus the night before. These were all done at a research center, a circadian research center with a fixed meal, et cetera. So overnight nitrate levels. Y-axis, you have women on the left, men on the right. And each bar, there's a circle, square, and triangle, represents mild, moderate, and severe sleep apnea. Now, when you have healthy, good sleep, right, you expect your oxidative stress burden to decline overnight when you're sleeping. You're getting restful sleep. We don't see that in obstructive sleep apnea, but what is really interesting here is you'll see the women had a stepwise dose-dependent increase in overnight nitrate levels, oxidative stress, compared to the wet men, mild, moderate, severe. So that is on the left. When we adjusted for a number of covariates, such as percent body fat, diabetes status, where they were in the glycemic, the hemoglobin A1C, smoking, we did DEXA scans looking at fat percentage. When we adjusted for all of that, there was still a robust association, and the women continued to show increased oxidative stress overnight. So females with moderate or severe OSA did not exhibit the expected decline in nitrate levels after a night of sleep. So these may be some of the mechanisms that is leading to some of this, what we're seeing now in the literature that's mounting with increased cardiometabolic adverse events in women. This is a study, this was published last year in CHEST. This is from my K-23 Career Development Award at Johns Hopkins. So this was a study that we did. It was a randomized controlled trial, and it was in people with type 2 diabetes. They got 3 months of PAP therapy, randomized to either get PAP or not get PAP therapy. And what we looked at is specifically glycemic variability. So we looked at, the continuous glucose monitoring systems. We were looking at dynamic measures of glycemia in these people. They had moderate to severe sleep apnea. So that was the primary objective. And I'm going to just walk you through this a bit. I don't expect you to see the detail on this, but the top few rows represent women and different outcomes, standard deviation, which was our primary outcome, mean glucose. The bottom half is men. And I've tried to highlight for you that we saw differences in the women. They got better with PAP therapy. Their glycemic control improved after 3 months of PAP therapy. The men, not only, they didn't even stay the same, they actually got worse. So there are sex-based differences even in response to therapy, and we know that to be true also with all these new GLP-1 receptor agonists that are coming out. We're starting to see difference, especially once the women hit menopause, okay? And you can see also, when you eat something, it's like a stress test. for your endocrine system, for your pancreas. And we saw that the women really responded beautifully to the postprandial glucose spikes after a meal compared to the men and at bedtime. So this is really important because that's what's associated with microvascular bad outcomes in diabetes itself. So just to summarize, we had sex-specific differences in terms of PAP therapy in women versus men, and you really saw great differences in the women. And this is what has inspired the current research we're doing at NYU, where we're looking at men versus women, PAP therapy, and then adding on some antioxidant things even. So it's pretty exciting stuff, and I think there's a lot to be done here. I'm going to end on just a couple of notes. Number one, I think sex is being increasingly recognized as a very, very important driver of human health, okay? I think the NIH is really trying to do a good job of that. This statement came out from them in 2018. However, this is what's a bit disappointing. So this is a slide, and I want to really end on this note. This is randomized controlled trials done in sleep apnea, central or obstructive, mostly obstructive. These are 8 studies over the last decade, okay? Each circle represents a study. And you can see here that the gray is the percentage of women, okay, in the studies. This was, when you pool all the data, this is over 8,000 participants, and under 19% were women. So this is where we can really do better. So when I'm trying to enroll somebody into a study, I put this slide up for my patients and say, look, we got to do better. We got to get involved. So I'm going to leave you with that thought, and thank you very much for your attention.
Thank you so much, Dr. Arora. I mean, what a compelling argument. When we think about women in sleep, I think one of the things we've done in sleep medicine for so long, and it served our purpose because we didn't know better, is that we could have this one-size-fits-all approach to how we diagnosed, how we screened, and even how we treated everyone. And I think now we know better. The research is there. And you know, one of the reasons I asked Dr. Mallampalli to join us is because of the work she's doing to raise this awareness. So, Dr. Mallampalli, hearing this clinical evidence and how strong it is, what can we do to raise awareness, and what is your organization doing to champion that effort?
I want to thank Nox team for inviting me today to give this presentation, and I hope you all are excited as I am listening to Dr. Arora's presentation. So for many years, for 15 years or more, I'd been advocating for study of sex differences with a focus on women's health. So it made me very happy to see that Dr. Arora presented that data on sex differences and also tied in with what's happening with the sleep apnea. So what I'm going to do is take a bit of a different approach. I'm going to talk about policy advocacy and take you a little bit through the history of why all of this is important, and then sort of tie in with what we're doing at ASAP. I want to share this cartoon with you. And this is from 1991, but in 1993, things sort of changed. If you look at this cartoon, it says that we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anybody. And it's true, it never did. And so women were only included in biomedical research since 1993. That is only 32 years ago. That's not too long ago. And so then what happened when women are not included in biomedical research? There were a lot of assumptions that were made. It was assumption that women were equal to men except in body weight and difference in reproductive health. There was an assumption made, let's just take 70-kilogram men and just use that standard for research. That's not true. We know that. Sex differences exist from head to toe. We know that information now, but at that time, there were a lot of assumptions that were made. And when it was done that way, and there was a fear for including women, especially women of reproductive age, because there was a fear that we are going to harm the baby. But it was just a blanket policy that was made at the FDA. Because of that, we saw a lot of things happen. We saw underrepresentation of women in research. We saw a lot of women were misdiagnosed and underdiagnosed, and we've seen that in sleep apnea, and lack of sex-specific screening tools and diagnostic tools that we're talking about today, and also increased morbidity in women. And delayed or wrong treatments, or delayed, that again, like Dr. Aurora mentioned, it takes many years to women to get diagnosed. More often they're misdiagnosed with having anxiety and depression, and it's just not in the sleep field. I've heard this everywhere, in cardiovascular, autoimmune, it's the same thing again and again. There's a pattern, how long it takes for a woman to get diagnosed. This is just a snapshot I'm giving you. In 2013, I attended a conference in Baltimore. In 2012, and around that time, there was a study that came out from National Sleep Foundation in America and Poland. We noticed that a lot of women were complaining of sleep problems. And there was also a paper we came across on gender differences in sleep. And so I was at the Society for Women's Health Research, and we were like, wait, where is the sleep health right now? And I attended a conference in Baltimore in 2013 and found there was absolutely hardly any talk on women. There was maybe one session, and right there I realized, well, we need to bring attention to this topic. Reached some of the leaders at the conference and said, well, I want to do a roundtable discussion, and let's talk about the gaps and opportunities in women's health. And that's what that paper is, Exploring Sex and Gender Differences in Sleep Health. It was a great paper, received a lot of national attention, and after that we established the Sleep Network at the Society for Women's Health Research, and we had a couple products that came out of it. One of them was the Women in Sleep Guide, and you can still find that on the Society's website now. I just want to share some of the facts here with regard to women and sleep disparities, and this applies to just sleep in general. It also applies to sleep apnea. We know that women's sleep is different across the lifespan. It's influenced by all these hormonal milestones, pregnancy, perimenopause, menopause. We know certain sleep disorders affect women differently than men. We know that with sleep apnea. We know that with insomnia. Women's sleep often is ignored, misdiagnosed, underdiagnosed, and lack of awareness among women and their providers. Even women don't know that they need to pay attention to the sleep. Providers never ask women how their sleep is. It's often assumed that women are stressed, they have too much going on, and that's why they're probably not sleeping. So that conversation never comes up. So we have to empower women with information and have them ask their providers, doctor, ask me about my sleep, because women inherently know if something is not right with them. And then this whole one-size-fits-all approach to research and practice that needs to change. That needs to change for sleep health, that needs to change for sleep apnea. So at ASAP, definitely this is one of our focus on women and sleep apnea. We are in the process of creating different resources, and with the same approach of helping women to advocate for themselves. On your left, you will see the Doctor Dialogue for Women. This was done in collaboration with one of our founders who has sleep apnea, and then she kind of came up with this concept, let's give this handout to women so they know what type of questions to ask their doctors. On the right is an advocacy toolkit that I was involved in creation when I was at the Society for Women's Health Research. On the front side is informing women what their symptoms might look like. And then once they look at the symptoms and understand that they might have sleep apnea, they can then go to their primary care provider and insist on getting a diagnosis. And on the back side is information for the provider, which walks them through what they need to do, whether order a home sleep test or then, and we also say if your home sleep test is negative, don't stop there. Go on to get a study done in a lab. And this resource has been very popular, and we're in the process of actually thinking of updating that now because there's some new information now. I want to share this slide just to show where we are right now. Women are the chief medical officers of their family. Women make the decisions in their home regarding their health, their family's health. So why aren't we marketing products to women, right? Women need to understand what's happening, yet we ignore their health. You can see 51% of our population is made up of women. 47% women are in the workforce. Twice the number of women are caregivers. Look at the healthcare utilization. 65% are women, and then 91% of women have health insurance, either through their employer or private insurance. I think we just need to change the way we think. We need to start thinking of women first and say, okay, what does matter? Because when you make the change, you inform the women, she will then think about her family as well. So what's next? I mean, this is something I've shared before too. I think we have to just all work together to make that change. Let's empower women with that information. So get them to take an active role in their health and ensure that they get the quality sleep. If they are healthy, their families will be healthy. Let's ensure that sleep providers are aware of women's specific health issues and concerns and not just make any assumptions about that. Enable sleep researchers to design clinical studies. It's not just the design, it's also important to analyze the data by sex and also report the data by sex. And this is something I've spoken many times. Put that in your title, put that in the method section, put that in your results. We have to start making those changes. And finally, encourage the sleep industry to evaluate safety and efficacy of interventions in women and men separately. Most often you'll see the adverse events are reported more in women, especially when it comes to drugs, because women tend to build a higher immune response, so their reaction to drugs are higher, and of course there's sex differences in pharmacodynamics and pharmacokinetics too. So we have to keep all of that in mind when we're designing or looking at efficacy and safety as well. Because after all that effort you put in, you don't want any recalls to happen. We've just seen that with Philips and sleep apnea. But again, recalls happen all the time, but these are some of the things that we keep in mind right at the beginning of creating something. And I think that's all I have today. So thank you all for your attention.
Excellent. Every time I hear Monica talk, I get excited because I begin to think about possibilities, and I think about what we can do to educate not just the men in our lives, but the women of what their possibilities are, because so many of them think of the rest of their family before they think of themselves. So when we can do that and have this education that we bring to our patients to elevate their knowledge and create that attention to what they do. So Dr. Baran, as we think about what Dr. Rohr shared from the clinical evidence and Dr. Malampalli of advocacy, what is Nox Medical doing to build diagnostic solutions to maybe elevate this conversation from a diagnostic standpoint?
Thanks, Emerson. And like Emerson, I'm very excited as well. I'll try to curb my enthusiasm and maintain my composure. All right, just making sure we're all synchronized here. So I'll first review some of the technical issues that limit the usefulness of HSAT and the diagnosis of OSA, and tell you about a solution that we developed. I'd like to introduce Jon Augustsson in our audience today friend and colleague who leads the team that created our AI scoring system. And Johan will assist with any technical questions that may arise. Thank you, Johan. All right. Okay, so we're all familiar with the different types of sleep studies. Type 1 testing remains the gold standard to diagnose OSA, and type 3 sleep testing is convenient but sacrifices diagnostic sensitivity. It was originally intended and is appropriate for cases with high suspicion of moderate to severe OSA, but it's often used as a substitute for in-lab polysomnography or as initial testing for everyone who presents with suspicion of OSA. We're also, oops, sorry. All right. Okay, now we know the limitations of type 3 testing, the HSAT. Actual sleep time can't be determined, so recording time is used, resulting in a larger denominator and decreased respiratory event index. Also, arousals can't be detected, so hypopneas can only be identified if they have a 3% or more desaturation. So hypopneas that result in arousal without major oxygen desaturations can make up a significant portion of the total respiratory events, especially in patients who don't have severe or more prolonged airway restriction. To see the impact of the HSAT limitations, we looked at 2,407 manually scored PSGs. We took a subset of the signals to simulate HSAT and rescored them. Here, each point represents one study with the corresponding REI on the y-axis, AHI on the x-axis. And at first glance, it's very obvious that the values are skewed with the lower REI numbers corresponding to the AHI numbers. But let's take a closer look. And hoping our animations will work here. Okay, great. So to better illustrate some important points, I'm going to add some color coding. First, for the AHI ranges of severity. And here we see the 0 to 5 in the AHI, the 5 to 15, 15 to 30, 30 and above, the standard ranges that we all use. And then I add some additional boxes here, color-coded boxes for the HSAT REI. Again, 0 to 5, 5 to 15, 15 to 30, 30 and above. And this further illustrates the mismatch in the AHI versus the REI. There's not a good agreement. Now, moving on to the next step of our viewing here. So again, same graph with the color coding removed, but this time just adding the zones of agreement. And again, we see that they don't agree very well. Now, first, let's examine from the REI perspective, first the 0 to 5 range. Here are the true negatives. Here are the false negatives. And we see that there are actually probably more false negatives, and the what appears as a 0 to 5 on the HSAT may indeed be 5 to 15, 15 to 30, or even above. So not only are the false negatives an issue, but the underestimation of the other ranges of severity. So we're all aware that many people use these same ranges that were intended for PSG severity gauging in the HSAT, and that doesn't really work. If we look at the 5 to 15, the so-called mild range of REI, these are the ones that actually fit that range when compared to the PSG. But most of them are actually in the 15 to 30, some even in the 30 and above severe range. Similarly, if we look at the 15 to 30, a lot of them are in the 30 and above range. The only range of agreement is really the severe range. So if somebody comes up with a severe index on the HSAT, we can be confident that it is indeed severe on the AHI if we were to check with the PSG. All right. So this problem has motivated us to develop the Nox AI scoring to address the limitations of HSAT while maintaining its simplicity for home testing. We know that breathing is affected by changes in cortical and chemoreceptive chemoreceptor control in wake, non-REM, and REM. Also the atonia of the accessory muscles of respiration in REM sleep. And there's also respiratory response to arousal. Without EEG, by using calibrated respiratory inductance plethysmography belt data, these characteristic breathing changes can be used to estimate sleep stages and detect arousals as well. And I'll show you an example. This is an example of the auto AI scored events, and you will see here that there are, the RA stands for respiratory arousal, and you will see that it has correctly identified identified arousals occurring without desaturation, which are what we're really missing with HSAT. So with this enhancement, home testing becomes more on par with in-lab testing, PSG type 1 testing for OSA. And we have a different picture with the limitations removed. Now, coming back to the original graph once again, let's take another look at this. I maximized my use of this graph. The zones of agreement once again. And moving on to, I'm going to now add the same studies rescored, the HSATs rescored using the Nox AI algorithm. And with that, here are the same points in comparison to the blue. So the HSAT REI values have all moved up for improved agreement with the PSG AHI values. I mean, most importantly, the false negatives have been markedly reduced, as you see, and the others have moved into the agreement zones. So bringing it back to the perspective of OSA in women, with this Nox AI scoring, we are able to identify OSA in patients likely to be missed with existing home testing methods. Patients with hypopneas terminating with arousal rather than with a desaturation can be identified much more effectively this way. And of course, this includes, as a large group within there, the women. So I will end with a quote from an Italian colleague, which I think sums up our situation in many ways, and I will turn it back to Emerson.
Excellent. So when we look at these numbers, they're staggering, and I hope that they're eye-opening. And when we think of the solutions that we have, are those solutions good or great? You know, I love this line from Jim Collins' book, Good to Great, that good is the enemy of great. I think a lot of times we look at our solutions and we think, are they just good enough? That I got a number, I can punch that and say, okay, yes, they have sleep apnea. It's almost like playing tag, right? Tag, you're it. Now I know the number you have. But one of the things that we've done at Nox is we've invested in what we call conclusive sleep testing. And what does that mean? It means that no one's left behind. No one's marginalized, whether it's their gender or the color of their skin. And I think that really matters, because for the longest time, we were able to use a broad approach because we didn't know better. But now we know better, and we should do better. And that's what we've committed to at Nox. So when we think of this and we think of the undiagnosed, I mean, when I started as a vendor in 2001, we were so excited about the market because we would say 90% are undiagnosed and untreated. That was 25 years ago. The number hasn't changed much. So we have to do a better job of identifying patients. And when we share this claim here, and if you've ever worked in any kind of industry, a claim is a strong statement. That means we have evidence. That means our regulatory department has signed off on it, which is a big deal. This is a strong claim of what we stand for as an industry and as your vendor for the best diagnostic testing in the market. And that's easy to say for me because, you know, I'm in love with it and I'm here to stay for a long time. But what we want to do at Nox is empower you. We don't want to give you good enough. We want to give you insights. We want to give you the capability of being able to test any patient and have confidence that the test you just performed gave you the data you need to make that choice, because it's sort of like going back to my family member. What would I do for my grandmother, my mother, my spouse, my daughters, my brand new granddaughter? She's less than a month old, beautiful. What do I want for them? Because I don't want good for my family. I want great. I want conclusive testing that's going to answer questions, that's not going to tell these women in my life that they're tired because they're moms and they're taxi drivers and they're schedulers and cooks and housekeepers, oh, and a professional, by the way. So that's the deal, right? We want to be able to have someone, because one of the things I tell the sleep technologists that I serve with is if somebody comes and sees a sleep doctor about a sleep test, that's actually a pretty big deal, right? They've come to that place of desperation where they want an answer. It's not an easy decision. It's not like getting your blood pressure taken. It's a big choice to step into a sleep doctor's office. It's a bigger choice to have a sleep test. And so when someone's asking for that, are we giving them the best possible answer, or are we just saying, tag, you're it? Here's a number, yes, you have it, here's your device, and we give them the Spock sign, live long and prosper. We don't want that. We know better now. We've got technology that can take a deep dive into our patient's journey, and we can take that with them. And in Nox Medical, that's what we're doing. So with that, I want to open up the floor for questions. We've got a few more minutes for our STEAM panel, so please step forward and share a thought. Well, I've got one for the panel. So Dr. Orr, what do you feel like is on the horizon when we think about women in sleep? Where do you see this story in 5 years?
So, okay, can everybody hear me? Okay. What I see and what I hope for is, first of all, there are multiple aspects. One is better diagnosis, better screening, better diagnosis, but also thinking about getting more specific in terms of treatments to really reduce the outcomes related to obstructive sleep apnea in women, because like I said, I do think there's now almost consistent evidence pointing to that it's worse. So focusing on outcomes, and a big part of that is making the right diagnosis. Excellent.
Dr. Malampalli, you've done a lot with advocacy. When you and I first met, we didn't actually talk about this. It was here at APSS. I was working for another company, and you walked in the booth and you asked me a question. That was what, 2015? Is that what we figured out? Somewhere in there? What was the question you asked me?
You're testing my memory. I think I asked you if you studied, looked at something in women versus men. I did ask you that, yeah.
And what did you find out?
No, there was nothing, nobody was doing that. And I think I remember I went to some booth and they had pink masks, I believe it was ResMed back then, which I thought was great thinking, a pink and blue mask. And that was the only thing that I found. But that was at least, a big news, something, yeah.
So where do you see advocacy going in the next 2 to 5 years for women? What do you envision the landscape looking like from the work you and others doing to raise awareness in Washington with payers, with our own community? What do you see?
I think there are a lot of challenges that I'm seeing in the sleep field. So it's going to take us a little bit of time, but then again, I also see a lot of changes in policies, and that's what we are here at ASAP to focus on. I think it's an exciting time right now, frankly, with innovation, with the focus on women and sleep. And so definitely I think we're going to make progress, and let's keep up that progress and continue to advocate for women. One thing that always struck out to me, because I worked in so many disease areas, chronic conditions, that women are almost always affected more than men. And I've always wondered, why don't we see that in sleep and with Nisha's results today. I mean, in a couple of the talks that I attended today, I think we're missing something, and let's see what that is, you know. So there's hope, and I think on our end we'll continue to advocate for OSA patients and continue to advocate for in looking at sex and gender differences, and hopefully we can educate more women to ask questions.
Excellent. Finally, Dr. Baran, you know, a lot's happening at Nox. You were able to highlight just a really key feature of being able to identify sleep disorder breathing in a really special way. As we look into the future at Nox, what do you see on the horizon that our participants here can look forward to?
I think that increased sensitivity of home testing is going to be a tremendous change in the sleep medicine world. Even though we currently may do a follow-up PSG on patients who come back with an REI less than 5, in many cases we know that's not true, and that's where it's ending with that home test. So, and even those who proceed with the two-step process, there is a dropout, a significant dropout rate. It's essential to have that, I think, initial testing that is convenient and sensitive and can identify OSA much more effectively and can be applied to this population of women. I think that that's going to be a huge change for us. And the same technology, the AI scoring technology we have, is also able to identify endotypes. And with this, we will also be able to, I think, add more value and more information to clinicians in how they proceed with treatment.
Excellent. We have a question. Laura?
Yeah, my question actually is paired on that. When you're looking at severity of sleep apnea in women, AHI, of course, is diagnostic, but to really understand the severity of their disease, is it the endotyping correlation that has to happen, or what's your feeling on understanding that? All right, I'm just wondering, you know, AHI is diagnostic, but for understanding severity, what else do we need to look at? Is it endotyping? Is it hypoxic burden? What other things can we look at to help women understand they need to get treatment?
So this is with our current state of affairs. I think all of the above, but with the enhanced sensitivity of the home testing with AI tools enabled, this sensitivity or the underestimation will be much less of an issue, if at all. So with the improved identification of OSA with sensitive AI scoring, that should be a thing of the past. Now, under current circumstances, of course, it's very difficult to figure out which ones are actually in the correct zone of correlation with AHI versus the ones who are not. And that's a difficult clinical decision to make without a lot more data, which really is the sensitive testing, and being able to identify those hypopneas with arousal only is the key point there, I think.
I just want to add to that. So the American Academy of Sleep Medicine has actually assembled, this is a very, the question you're asking is a very important one, and they've actually assembled a task force that is going to look at sort of re-envisioning OSA diagnosis and the AHI and taking into account, like they do for other disease processes, right? Patient-based symptoms, things, what are the best physiological metrics? So that is underway. They actually talked about it at the membership meeting, but that is definitely on the horizon. So I think that's going to address some of these issues that we continue to struggle with as clinicians. Incorporating patient-based symptoms, incorporating the best physiological parameters, not getting rid of the AHI necessarily, because it has served us well in many ways, despite its problems, but really enhancing it and helping to make the best diagnosis and the most accurate diagnoses in our patients.
I just want to add to that. That was really a good question. I think we definitely need better biomarkers. And I think we're at a time where innovation is happening so fast, the science also needs to catch up, right? I do also want to say, please visit, I don't know if it's time over, but we did put out a poster today. We did one in partnership with ApneaMed, the SHINE study, where we were looking at the psychosocial burden and did a gender differences and saw the psychosocial burden was much higher in women. So that's to your, where you're talking about even gathering that kind of data, what are women saying versus men, will also try, we need to take that into consideration too.
And if I just may add one comment in reference to a previous comment made regarding the severity and prevalence of the comorbidities of OSA in women, perhaps as a consequence of waiting until it becomes obvious enough to show up on these less sensitive tests, could be a factor there, just logically from just a practical perspective. And catching it early and treating it may have some impact on that.
It's interesting you say that. I was actually in a discussion this morning where one of the problems in this particular market was that patients were being referred and being diagnosed as not having sleep-disordered breathing, but they probably didn't meet the criteria from a screening standpoint. So later in life, what are they faced with when they have that conversation about sleep-disordered breathing and they're asked, do you have it? And they know, I've already been tested. And so they totally miss out on being treated appropriately in care. So, great one. Thanks, Laura. Anyone else? I know we're out of time. One more.
So we're kind of talking about the differences in diagnosing. Do you think there could be a difference in treatment? Like we see CPAP as the gold standard for treating OSA, but is that also the gold standard for women? Is there gender differences in the response to treatment?
Yeah, so I mean, the study that I highlighted, the hypno studies, that has kind of made me more aware that there could be therapeutic differences, and the data on therapy is not very robust right now. There's some data, it's mixed about adherence hours. More women need more in REM. They have this more sort of REM-related phenomena. Oral appliance therapy, there's a little bit of data out there, but we need to get better at that. The GLP-1s seem to work really well in women initially, and then as they hit menopause, they don't seem to work as well as they used to, and so there's sort of like they have a better response initially in terms of their OSA, et cetera. So I think there is definitely differences that are going to emerge as this line of work gets more robust in terms of seeing differences in therapy. And it's all towards, what these guys are doing, like trying to endotype and see like where we can kind of hit on those things. And I think we're going to find out that we can probably endotype pretty easily in the home and really focus in on therapy that way as well. So I think seeing that one size, repeating that theme of one size does not fit all is important.
Excellent. Well, I want to thank you all for being here today. Again, on behalf of our CEO, SK, and our CMO, Dr. Heidi Riney, we want to thank you for joining us. This was a fantastic discussion. I'm especially thankful to our esteemed panel. Please give them a hand. We hope you enjoy the rest of the conference. Thank you so much.